Can you see me? I have no
Right.
idea why this records. Oh, you are recording. Okay, sorry.
Yeah, yeah. You could
So,
make it as a full screen. Yeah.
yes. Um, okay. Thank you for the kind introduction. And in the next, I'm trying to minimize so that this. Um, so in the next few minutes, I'm going to talk about acute and long-term complications of immunotherapy. This is not as, I'm going to hopefully I'm going to break it down so that it will be like you all can come out with like one or two take home points. I think this is one of the simplest take home message I can tell in any in my lectures, this topic. Okay, next slide. I don't. Okay. So coming to the complications of immunotherapy, they are not uncommon. We see them very frequently. A study suggested that there are like 69%, the incident prevalence rate is 69% for acute IRAEs, immune-related adverse events, and then 43% for chronic immune-related adverse events. There's a lot of literature about acute immune-related adverse events, but our understanding of chronic events is still evolving. There's not much about it. We're slowly learning about the long-term effects. So in the next few minutes, I'm going to review about the mechanism of action or the pathophysiology of the immune checkpoint, the mechanism of action of these immune checkpoint inhibitors, also known as immunotherapy, and understand the pathophysiology of their adverse effects. So we're also going to illustrate these side effects or complications on imaging. And then I'm going to show also like, which is a topic dear to my heart, is something like how the disease evolves over time. What happens to these findings over time? So when something presents as acute findings on imaging, how they go over, what they become over time is that also I'm going to illustrate in some select cases. And then obviously the temporal evolution, and then what are the long-term sequelae. So coming to the bird's eye picture, like what is immunotherapy and like how they act. So we all have fortunately, our immune system tries to prevent cancer on a daily basis. So our immune system prevents cancer by eliminating viruses, hence viral-induced tumors. It also results, in prompt settling of the inflammation, basically resolution of the inflammation. Now there is so much emerging literature about immunogenic or like an inflammatory environment leading to tumors. So immune system plays a role in not only clearing them, but it also like it gets inactivated in a timely manner. The inflammation subsides and everything settles back to normal. Immune system also identifies and eliminates cancer and precancer cells. That is its job 24/7. Now, what are immune checkpoint? What does the immunotherapy do? So there are some pathways in our body which are called immune checkpoint inhibitors. In immune checkpoint pathways, these pathways actually inhibit or normally suppress T cell function, so that once the immunity is activated, it needs to come down so that our body doesn't activate and go on like fire, killing everything, including our own tissues. So these are the pathways, inhibitory pathways that prevent autoimmunity and protect normal tissue from collateral damage. So so what does a tumor do? It's like a catch, like a Donga police game, right? The immunity does something, trying to catch the cancer cells. Cancer cells try to do something to avoid. So the immune therapy, the cancer cells can avoid immune system detection by exploiting some of these pathways. And what does the immune checkpoint inhibitors do? So these immune checkpoint molecules, so basically these are the molecules in the pathway, and their inhibitors kind of activate this pathway again, kind of inhibit this pathway, inhibitory pathways, so that the T cells keep on fighting or keep on detecting. So here is one of the mechanism. One of the molecule is CTLA4, which is cytotoxic T lymphocyte associated antigen 4. So what does that do? So the antigen presenting cell, whenever an antigen presenting cell or like macrophages or something, they detect a tumor cell, they present an antigen to the T cell receptor. They also co-stimulate there is another molecule called B7, which co-stimulates, which attaches to this molecule here. So whenever this gets excited, this also get excited. This binds it and excites. So this excitement or binding results in a feedback loop, which inhibits, which results in expression of CTLA4. So which is a feedback loop, basically. Your immune system you don't want your immune system to go on fire. So this CTLA4 comes in and binds and inhibits this activated T cell. But in a tumor context, this can lead to tumor growth. But in a regular immune system activity context, this stops the fire and lets the healing or process starting. So this is inactivated and the T cell goes. So once you give anti-CTLA4, which is the immunotherapy molecule, this inhibition is stopped. Now, the activated T cells remain activated. The second molecule is programmed cell death protein 1 and its ligand. So those molecules, this is a pathway. Here, the T cell is activated by, this is the antigen from the tumor, by the tumor cells. So activated T cells produce something called PD-1. And so once these T cells are activated, the natural feedback mechanisms start in and they activate this PD-1. And these activate this PD-1, it binds to a receptor on the surface of the cells. And if the receptor is called PD-L1, if this binding happens, it inhibits the T cell. It stops its checking function, tumor checking function or tumor growth stopping function. So that is inhibited. And these other immunotherapy molecules either target the PD-1 or PD-L1. So where are these? So here are these cells expressing the immune checkpoint molecules and commonly used immune checkpoint inhibitors or immunotherapy. So as I said, cytotoxic T cell lymphocyte associated antigens, they're expressed exclusively on T cells. They down-modulate the amplitude of early stages of T cell activation by contracting the activity of the T co-stimulatory receptor. So one example is ipilimumab. The programmed cell death protein, it is expressed on T cells, B cells, natural killer cells, monocytes, dendritic cells. They limit the activity of the T cell in the peripheral tissue at the time of inflammatory response to infection and to limit autoimmunity. What stops them? What are the inhibitors? For PD-1, it is nivolumab, pembrolizumab. These are the commonly used immune checkpoint inhibitors. These three are used widely, even here at MD Anderson. This is also sometimes like we are using atezolizumab and durvalumab are next commonly used. So programmed cell death ligand 1 inhibitors, they are expressed by antigen-presenting cells. They're also found in normal tissue, normal non-hematopoietic cell membranes and tumor cell membranes. So as I said, like tumor cells also become smarter. So they commonly evade immunosurveillance. So by upregulating these PD-L1 molecules. So that's how they try to survive in that environment and grow. So coming to immune-related adverse events or complications of immunotherapy. So there is a seminal report that came out about chronic IRA. So I was, sorry. So there are a lot of articles, as I said, that were published about acute. There's also very few that came out on chronic. So this Patrinley et al. Have analyzed some 387 patients with high risk resected melanoma treated with anti-PD-1 immunotherapy. They found a very high incidence rate for acute IRAs, which is around 69%, and 47% for chronic IRAs. And then of these, 60% with acute, the complications persisted into chronic toxicity. And the interesting thing is they found that these are all like half of which were symptomatic, the others may not be symptomatic. Acute IRAs, they defined acute immune-related adverse events as those arising during the treatment with immunotherapy, while chronic events as those that persisted beyond 12 weeks of treatment discontinuation. So of these, endocrinopathies are very common: arthritis, xerostomia, neurotoxicities, ocular events more likely to change from acute into chronic. But the immune complications associated with the visceral organs like liver, colon, lungs, kidneys had much lower rate. So bottom line, they said chronic immune-related autoimmune effects are more common than previously recognized. So there are other studies also that have reported about higher incidence of long-term toxicity. And the caveats being these studies are not based on imaging findings, and not all complications reported are associated with. And we know that sometimes nephritis is a clinical presentation. Patient present with renal failure and imaging doesn't show much findings. And not all imaging. So sometimes, conversely, sometimes we see imaging abnormalities, but the patients are not symptomatic. So what are the mechanisms of immune-related adverse events? So basically, all these molecules, they upregulate our immunity. So basically, they activate T cells, they activate humoral immunity, which results in increased which could also result in increased autoantibodies. They decrease the activity of T regulatory function, cross-reactivity. Sometimes the antigens can cross-react with normal tissues. The tumor antigens can cross-react, and all this can result in upregulation of immunity. This is one of the paper published my colleagues from thoracic imaging. So what are the organs affected by immune-related adverse events? Pretty much any organ can be affected because it's basically inflammation. If your immunity goes haywire, it can affect anything. So, but imaging findings they described in the brain, pituitary, thyroid, vessels, pneumonitis, myocarditis, pericarditis, adrenal glands, adrenalitis, hepatitis, pancreatitis, colitis. So, so those are the ones that are pertinent to the radiologist. But the most common, of all this is the dermatitis or pruritus. Patient present with like itching, rashes, of every dermatological manifestation. I was reading about it. There are a lot of things that happen. So thyroid, the next common is thyroiditis. So it presents with thyroiditis, and then it results to it can become hypothyroid. So initially, the thyroid gets inflamed, and you see the symptoms of thyroiditis, and that becomes hypothyroidism. Arthralgias, colitis, diarrhea. This is one of the things that I see as an abdominal radiologist very commonly. The clinicians just say, like, patient on immunotherapy, rule out colitis or something like that. We do very often many CTs of the abdomen. Hepatitis is kind of not very satisfying because sometimes most of the times patients present with elevated liver function tests, and we don't see much on imaging. Pneumonitis, we see changes on CT, xerostomia, adrenal insufficiency, hypophysitis. So these are the common. Uncommon ones are pancreatitis, diabetes, gastritis, enteritis, hematologic toxicities, mucositis, myalgias, and you can see myocarditis, neuropathy, ocular toxicities. So pretty much every organ is involved. It's just that what we see in imaging, that is what I'm mostly talking about today. Chronic, so those are acute. Coming to chronic immune-related adverse events, thyroiditis again is the first common one. Patients also have dermatitis pruritus that can become chronic dermatitis, arthralgias, adrenal insufficiency. I've seen patients with basically adrenal insufficiency, like that on lifelong supplementation. Xerostomia, hypophysitis, Guillain-Barré syndrome, Bell's palsy, myasthenia, they very rarely become chronic also. Uncommon ones, colitis, diarrhea, persistent colitis, diarrhea, hepatitis, pneumonitis, pancreatitis, diabetes, gastritis, enteritis. Some of the patients who present with acute pancreatitis can become insulin dependent. Very small fraction of them. Most of them are asymptomatic, but a small fraction can develop insulin-dependent diabetes. Mucositis, myalgias, these are the other chronic findings. Imaging findings, pituitary, you see stalk thickening and enhancement, diffuse enlargement. So the imaging findings, I can tell you from the beginning, everything is like, if you can catch them during the acute inflammation, everything that will be enlarged. If you're not, then you see variable degrees of atrophy. Some patients completely revert back to normal, the others are not. So that happens in pituitary, thyroid gland, salivary glands, basically diffuse enlargement during acute and followed by atrophy or variable atrophy. So lungs, so you see basically imaging findings are patients present with cough, dyspnea, hypoxia, in temporal association with the starting of the treatment. So you have to correlate when the treatment, if the patients are on immunotherapy, when the immunotherapy started, and if they ended, when they ended. But if these findings happen during, if you see these findings during and around the time of, around or immediately after stopping immunotherapy, you have to consider immune-related adverse effects. So the lung findings are non-specific. You can also think about infection in these patients, but once the patient is on immunotherapy, you always give differentials. Ground glass opacities, organizing pneumonia, they improve with holding immunotherapy or steroid treatment. There are not many long-term sequelae on this for this finding, maybe rarely some minimal scarring, but you see minimal scarring with pneumonia also. Adrenal glands, there may be diffuse enlargement due to adrenalitis, but adrenal is so small and so variable sometimes, and potential atrophy. So these changes in adrenal volume are really hard to actually detect on imaging. But the symptoms are like, the patients are symptomatic. Pancreas, this is what I worked on. I published about the serial imaging findings of pancreatic volumes in patients who had pancreatitis from immunotherapy. So basically what we see is they can be symptomatic or asymptomatic. They're asymptomatic patients with elevation of lipase or MLAs. There can be diffuse or focal enlargement of the pancreas. And then the common thing is elevated pancreatic enzymes. Peripancreatic edema may or may not be seen, variable degree of long-term atrophy, rarely patients present with fulminant diabetes. And these patients also showed variable degree of atrophy. Serial volumetry, if you do them, it's associated with volume loss. That can be symptomatic or asymptomatic also. Colitis is the most common reason why we image these patients. They present with diarrhea. CT findings include mesenteric vascular engorgement, diffuse or, so this can be also like diffuse or segmental, predominantly colonic wall thickening. Sometimes you can see other GI tract involved, but colon is the most common. There's fluid distension of the colon. Gastritis and enteritis are rare, but again, same thing, diffuse wall thickening enhancement. Kidney, I haven't seen any findings in the kidney. Much, but the patients, I've seen patients presenting with renal failures, but imaging wise, not much. So hepatitis and cholangitis is another reason why we image. patients. So that is another most common presentation is asymptomatic rise in transaminases. Imaging findings range from normal liver to hepatomegaly to periportal edema or heterogeneous liver parenchyma, heterogeneous enhancement of the liver. So sometimes we say cholangitis, rarely, like I'll show you some examples where there may be variable intrahepatic biliary ductal dilatation, wall thickening, enhancement of the bile ducts, gallbladder, periportal edema. I haven't seen any long-term sequelae of these findings. Arthritis, patients have complained of long back joint pains, MRI are synovial thickening, synovial enhancement, and joint effusion. PET-CT sometimes shows periarticular FTG uptake with common symmetric involvement of large joints are more commonly involved in a symmetric involvement of uptake, symmetric uptake in many joints. You can raise the possibility of arthritis. Sarcoid-like reaction. This is something we see very commonly, like patients on immunotherapy have symmetric enlargement and uptake in the hilar and mediastinal nodes and some lung nodules, similar to sarcoidosis. And these patients, if you don't understand that it can be a complication of immunotherapy, patients end up getting called as progression. But if you give heads up that if you keep the other possibility in mind, maybe it will save patient and clinicians some trouble, right? We have to consider the second possibility as sarcoid-like reaction. And then it's not only one organ at a time, they can involve multiple organs, either simultaneously or sequentially, and these multiple organs can show variable response to treatment. So this is how the immune-related adverse effects are graded. Asymptomatic or mild symptoms, moderate in severity, severe life-threatening consequences, and death. So I think coming to the illustrative cases, I guess this is all theory behind, like we can leave the theory behind. You can see the actual cases. So these are the common ones. Symptomatic, so pituitary hypophysitis. So you see, this is a normal gland after 1 month of immunotherapy. This is before immunotherapy, after 1 month of immunotherapy, diffuse enlargement of the pituitary gland. And maybe some atrophy, but again, pituitary is such a small gland. So the volume loss, it's difficult to appreciate volume loss unless it's completely atrophic. But maybe it's like minimal volume loss here. But thyroid, you can see very appreciable volume loss. So this is before immunotherapy. This is a thyroid gland. 2 months around the time of like where they at this point they can present with pain or like the thyroid increased TS, the thyroiditis findings. So 2 months of immunotherapy, the patient has diffuse enlargement of the thyroid, and then the thyroid atrophies. That's you can't see basically after 3 years, like you basically show we cannot see any thyroid left. There's maybe tiny sliver here. So patient with xerostomia, another complication is the parotid gland enlargement. So sialadenitis, the patient has, and then followed by xerostomia. So this patient before immunotherapy, there is diffuse enlargement of the parotid glands. So before this is the size of the parotid glands, and then after immunotherapy, you have diffuse enlargement, and then there's atrophy of the parotid glands. Lung findings. So basically here you can see very patchy interstitial and alveolar. Interstitial and alveolar opacities. That's diffuse. So this is after completion, and then they give steroids. So complete normalization of the immune findings. Again, another patient, symptomatic pneumonitis. The patient had 4 cycles of immunotherapy, developed cough and shortness of breath, along with elevated liver function tests. This patient was treated with steroids and infliximab. So the ground here, 2 months into the ICI therapy, the patient developed ground glass opacities, multifocal opacities, which are slowly clearing. And 1.5 years later, you don't even see that. But around the same time, when there was elevated liver function test, there's not much abnormalities on the imaging. We didn't see much. Pancreatitis. So this patient had asymptomatic focal pancreatitis. And what is surprising is like, this is before immunotherapy, this is the tail region, head region. And after immunotherapy, so the head appears normal, but you can see diffuse enlargement of the tail. And further, I mean, these are all asymptomatic. So this happened like during a retrospective review when I was looking for something else. So when I went back and looked into this patient's history, and then if you correlate with the timing of the immunotherapy, at some point the patient had this pancreatic tail focal enlargement and minimal peripancreatic edema. So around a few months later, the patient is still on immunotherapy. The tail has atrophied, but the head shows diffuse enlargement here compared to. So you see all these fatty clefts in normal pancreas. When there is edema, you lose that. So all the normal like lobulations of the pancreas, that will be lost or decreased, blunted. Here again, and further continuation, the pancreas is now atrophic. The head is also atrophic. But this patient remained asymptomatic throughout. This is a symptomatic patient, a patient presented with abdominal pain, elevated serum lipase and amylase. During the time of elevated amylase, there is diffuse enlargement of the pancreas, minimal peripancreatic stranding, and then mild atrophy. The atrophy may be like, unless you do volumetry, sometimes we may not appreciate the pancreas still looks normal. But if you compare to pre-immunotherapy, you can see still like it looks smaller. This is again, this patient, symptomatic pancreatic injury. This patient presented with diabetic ketoacidosis. So that's how he presented with 4 months after immunotherapy. At the time of diagnosis of diabetic ketoacidosis, imaging was done, and you can see diffuse the pancreas. You can see all these tiny, tiny clefts. You don't see anything. Everything is blunted. There is mild diffuse edema. And after a few months, the pancreas atrophied. Another patient who developed adrenal insufficiency and if diabetic ketoacidosis. So here is the time, here's the pancreas at the time before immunotherapy, while when the patient presented, by the time the pancreas is completely atrophic. And also like, oh, sorry, this is also like adrenal gland. Maybe if you can see slightly, it might be like around the time of presenting, you can see slight enlargement of the adrenal gland, maybe atrophy. But again, here, without the clinical context, if you show the patient, same imaging studies are shown, you wouldn't comment them. Adrenal is really difficult to know. And this is just in the context of all the findings we are seeing in other organs and the clinical context. Necrotizing pancreatitis. So this is very rare. I've only seen one patient who developed necrotizing pancreatitis. This is so far. So this is a patient before immunotherapy. This is the pancreas. Follow-up 3 months after initiating immunotherapy, the patient presented with abdominal pain and elevated lipase. And you can see it's all necrotic. There is also gas. And then obviously the patient developed atrophy. One of the common things we find is immune-mediated colitis. So we frequently see CTs from our acute care facility, and patients on immunotherapy come with bad diarrhea, bloody diarrhea. And when we do imaging, you can see again diffuse or focal wall thickening of the colon. There is fluid distension. So entire colon may be affected. There's all wall thickening, or sometimes there is only rectum or sigmoid colon will be involved. But this patient had diffuse involvement. And everything came back to normal like after stopping immunotherapy and giving steroid. There's another patient, so patient with renal cell carcinoma. here you can see this is, I don't have the images during, so basically this patient had metastatic renal cell carcinoma to the lungs, nodes, and brain, which I'm not showing. Everything is and complicated by colitis that was treated with steroids, and I don't have those images in between where the patient had colitis and he was treated at an outside facility. Then the patient received more immunotherapy and developed recurrent colitis. They started on another treatment, again treated with steroids. So basically here what you're seeing is like the long-term complication is like diffuse lead pipe kind of rigidity, like there is loss of haustral pattern. How you see in ulcerative colitis, these like in the patients with long-term ulcerative colitis. So these are the findings that we are seeing here too, like the haustral pattern is lost. It's like lead pipe or diffuse. It's a straight tube compared to a curvy tube. Another patient with lung cancer with adrenal metastasis. This is before immunotherapy. After immunotherapy, the treatment, the mass has responded. Like it is very irregular here. It became almost fluid density, like well defined. But what we started to see is around the time the patient developed abdominal pain, nausea, vomiting, elevated liver enzymes. This patient had liver biopsy also, which showed immune-mediated cholangiopathy. So you can see subtle wall thickening of the bile duct. And this is initially like mild bile wall thickening. At 10 months, again, you can see more wall thickening. And here there is gallbladder mild thickening and enhancement. This is more fluid distended compared to what normally. This is cholangitis, and then this is cholecystitis. We can see common bile duct wall thickening. So this patient had both immune-mediated pancreatitis and hepatitis. So 15 months after starting immunotherapy for elevated liver enzymes, heterogeneous. So all we see is very heterogeneity of the liver. There may be some prominence of the bile duct. Non-targeted liver biopsy showed periportal inflammation associated with cholangitis. Again, the biopsy showed that. Pancreas showed volume loss. Here you can see volume loss, right? The pancreas is like very atrophic. So what happened 4 months before that? This one, the pancreas patient had diffuse enlargement of the pancreas. So that pancreas at that time, he was asymptomatic. I'm not sure if he was symptomatic or not. So, but 4 months back, prior to all this presentation with hepatitis, the patient had pancreatitis. This is what I was talking about, sarcoid-like reaction. This is something very commonly seen, and everyone has to, like reading PET CTs, has to keep this in mind. What we see in these patients is this is before immunotherapy. 5 weeks after immunotherapy, the patient had multiple avid lymph nodes. So this will be the distribution, hilar, mediastinal, around these nodes. So this is a symmetric, like in paratracheal and hilar lymph nodes will be showing uptake. Like here, this distribution is very characteristic of like sarcoid disease and or sarcoid-like sarcoid-like reaction. And this patient also has uptake around the large joints. So this is multiple joint arthritis and also sarcoid-like reaction, which so a follow-up, the patient received steroids, the lung has improved, but the joint disease is still persistent. So sometimes they show variable treatment response, like different findings show different responses to treatment. Some of the rare immune-mediated adverse effects. So this is a patient with metastatic melanoma on immunotherapy. The patient developed hiccups, nausea, vomiting, hallucinations within 2 weeks. abnormal movements of the extremities, and you can see there is diffuse edema in the cerebellum. You can see around this, like in the brain parenchyma, in the temporal lobes medially. So this is immune-mediated encephalitis. The patient did not improve with IVIG treatment or pulse steroids, and this patient actually died from complications. Another patient with optic neuritis, this patient had metastatic urachal adenocarcinoma, received nivolumab, and presented with visual changes in the right eye. You can see subtle thickening and enhancement of the right optic nerve around the optic nerve compared to the left side. So visual change is graying of vision lasting seconds that resolve with steroid treatment and discontinuing immunotherapy. So I think it's very important to recognize all these complications, all these symptoms as complications of immunotherapy, and then evaluate and then communicate those findings to the clinicians. So this is a patient with metastatic epithelioid angiosarcoma treated with immunotherapy. So there is wall thickening and, like, you can see uptake along the aorta. This is vasculitis. This is another complication. Another complication is myositis. This patient has renal cell carcinoma who was treated with nephrectomy 1.5 years back. So the patient developed biopsy-proven lung metastasis. Then he was presented with, then he was given immunotherapy. So after two cycles of this immunotherapy, nivolumab and ipilimumab, the patient presented with shortness of breath, difficulty climbing stairs, diffuse joint pain, muscle weakness, dysphagia, hoarseness of voice. So lab showed elevated liver function tests, creatinine kinase, troponin T. EMG also showed findings of myasthenia gravis, which is like nerve involvement, neuromuscular junction involvements. Muscle biopsy, so MRI showed diffuse, like not diffuse, but patchy areas of enhancement here within the muscle. This is post-contrast T1. There is edema, patchy edema within the muscles of the left thigh. Muscle biopsy was negative, but they also did a biopsy of the patient. Cardiac MRI didn't show it here. It was negative for myocarditis, but this patient had right ventricular myocardial biopsy, which showed myocarditis with lymphohistiocytic infiltrates. So this is patient is diagnosed with immune-mediated myositis and myocarditis. So the immunotherapy was discontinued and was aggressively treated, and this patient survived and recovered from toxicity. This is another case from literature from our colleagues. So there's myocarditis, immune-mediated pericardial effusion. So in conclusion, I think so our understanding of imaging findings of temporal evolution is still evolving. Chronic sequelae, in our experience at least, chronic sequelae of variable volume loss on imaging is observed with endocrine and exocrine glands. However, no definite sequelae were observed in visceral organs like lungs, liver, and kidneys. In our experience, concurs with the study reported about chronic IRAEs. And so asymptomatic so what are the clinical implications of this? So basically what we need to remember in this is asymptomatic or symptomatic diffuse or focal endocrine or exocrine gland enlargement followed by varying degrees of volume loss on imaging with or without associated functional impairment is observed in patients receiving immunotherapy. Imaging plays a key role in confirming or diagnosing suspected or unsuspected chronic immune-mediated adverse reactions. Again, in our experience, unsuspected findings on serial imaging could potentially be the only clue for diagnosis of immune-mediated adverse events in some patients. So some patients, sometimes like pancreatitis, it's only like focal pancreatitis case that I've shown you. It's only on imaging that, to looking back at multiple studies, we found that this patient had pancreatitis. by confirming volume loss with serial measurements, the role of imaging. So imaging can help elucidate understanding of the immune-mediated adverse events. And also like all these autoimmune diseases, because this is all similar to autoimmune, hopefully at some point, as our understanding of this immune-mediated adverse effects evolves, hopefully the treatments for autoimmune diseases also improves. Here are my references. Thank you.
Thank you, Sireesha. That's something very new for us because most of hospitals have just started using immunotherapies for the past couple of years. Maybe it might be some more time, and with our increased vigilance of our radiologists and clinicians, where you might see these findings. Two questions from my side. Are there any specific drugs which are associated with certain reactions more than compared to others? Number two is it's always about differentiating whether it's an infection or whether it's a adverse event to the drug. Are there any particular histological markers or something where you tend to be sure of differentiating between both?
Histological markers, I don't know, because I think the pathologists basically they say it if they don't see in any organisms, and maybe they sometimes they say it is in our biopsy reports, they confirm it could be immunological response. And coming to, I've seen with all kinds of immunotherapy, but the most commonly used immunotherapy at MD Anderson are like nivolumab, ipilimumab, and pembrolizumab. Those three I've seen. I didn't notice much differences, but we didn't. But if it is combined, we have more. When it is combined immunotherapy, there is higher chance of higher adverse effects. So combination immunotherapy, like some patients with get ipi and nivolumab combined, so they have higher incidence of more complications or more volume loss on imaging also of pancreas in our study. But I think it's mostly like whether the patient is on immunotherapy. From a radiologist standpoint, are they on immunotherapy or not, rather than particular immunotherapy. And I also, I might have read, but I don't remember exactly, like with anti-CTLA4, which is one of those immune checkpoint inhibitor, which is ipilimumab. But I didn't check for those one particular immunotherapy causing more side effects compared to others.
Thank you. I have some oncologists as well in the panel. If somebody wants to comment about their experience and any others as well, or you could type in the chat box. So if there's an acute event or acute adverse event, do they stop the drug or how do they go about it? They give steroids and continue the drug, or?
It depends on the severity. I think like if something like myocarditis or encephalitis, they stop. I mean, I think most of the times they stop too, and then re-challenge. They stop, treat them with steroids, IVIG. There are other infliximab that I don't know much about, but there are other anti-inflammatory drugs that they're using. Basically for all those autoimmune disorders, same drugs they're using. Plasma exchange. Some patients get plasma exchange that also aggressive treatment. So
Yeah. So when I talk to my oncologist, he says the most common diseases which are treated with this immune checkpoint inhibitors here are melanoma, and then
melanoma.
renal cell
Yeah.
carcinoma and lung carcinoma. He says
Those
these
are
are the
the
three
three.
common things where we tend to use these drugs.
Yeah, but I think that is what our experience is. But they're kind of increasingly using for different cancers also. Like you start seeing them for lymphomas also, like sometimes acute leukemia. I've seen like one of the protocol having it. So they're expanding their the treatment the spectrum of tumors that are being treated with
Yeah,
immunotherapy. But the most common are renal cell carcinoma, melanoma, and lung cancer.
lung cancer. Yeah, that's what he was saying. They've started using it for anything and everything now, most of the times. They're expanding the indications, whether time only would tell whether what are the effects or response rates to these drugs. Yeah,
Maybe
some chats for you. You could comment on that.
we commonly see the lung problems, pneumonitis. Yes. Pneumonitis is, we see that too, but sometimes like all these patients have infection also. So there's no way we can say it is pneumonitis or not. I just give all the differentials saying since this patient is on immunotherapy, another differential consideration is immune mediated side effect, immune mediated pneumonitis. So it'll just I mean, for pancreatitis, at least you can say there's not many drugs can cause pancreatitis, but for immunotherapy pneumonitis, like most patients can have pneumonitis anyway. So we just give differential, and I think anyway they're going to get antibiotics and stopping the drug. The important thing is stopping or understanding that these patients have possible there is possible immune mediated pneumonia. So this is not going to go away with antibiotics.
Yeah, I think you must be working up for infection as well whenever you find a opacity in the lungs. Uh,
Yes, I think they all get antibiotics anyway.
okay.
So any specific predisposing factors which will increase adverse effects? Combined chemotherapy, combined immunotherapy is the only thing I know. Other than that, I'm not sure any other specific factors.
The main factor, Sireesha, nice presentation. Nice to know. The rare
Thank you.
presentations are we don't see. I'm an oncologist by profession. We use commonly in the lung and
Mhm.
sometimes in melanoma. Melanomas are very rare in this part of the world in Asian countries, not so common. And the prognosis is, when it is metastatic, its prognosis is very poor. Surgery is the treatment of choice, I do agree. But other side effects, we are not commonly seeing them so commonly. Thanks for the nice presentation.
Maybe the immune, like I've also read about some articles like your gut, the relationship between gut microbiome and immunotherapy response. So maybe the gut microbiome in Indian population is different compared to.
Exactly,
So
I do agree because the food habits, the other microflora and everything are totally different from Asian to the European and especially American side. But the studies yet to come out to confirm that it is because of the diet or microflora and all.
you
Are
don't see
you?
colitis?
No, I didn't see the quality. I used pembrolizumab in 3, 4 patients, atezolizumab in 2 patients of hepatocellular carcinomas. Uh, it is only for limited 3 to 4 cycles because the cost is burning them. The patient is
Yeah.
dying of cost rather than the disease.
Yes,
That's,
unfortunately, these
it's
are
so
very,
unfortunate.
yeah.
I didn't
Now
come
that
across.
yeah, at TISO, I didn't see also like many hepatocellular carcinomas. I didn't see them with any of the other complications so far. But that's not very commonly used also, like where our main population is melanoma, renal cell
Mm.
carcinoma, lung cancer. Those are all.
Renal cell also we are putting them on TKS rather than the other immune checkpoint inhibitors. Mainly, it's a limitation with the cost.
Yeah, okay.
Thank you. Thank you, Ishwar.
Yeah,
Yeah.
thank you. I think it's the cost is one thing which is a limiting factor here for the regular use as compared to the standard chemotherapy. Dr. Archana is here from Iowa. You want to comment anything about lung changes and your experience with that? Uh, I think she must be muted. Dr. Archana is a thoracic radiologist from Iowa. Uh,
Okay.
I think she joined late. Okay, then, Sirisha, there are no other comments from that. Thank you for introducing us to this concept of immune checkpoint inhibitors as well as the radiological manifestations. I think we might be better off being able to diagnose them and trying to triage them in the future.
Yeah, it's basically simple thing. It's at the time of acute inflammation, you have volume increase or edema, and then they have variable atrophy, variable inflammation, variable atrophy. If you keep that
Yeah.
in mind, I think everything comes into a bigger picture. That's a bigger picture.
Yeah, I guess with organ atrophy and dysfunction also follows. Hypofunction, dysfunction follow
This is
with the
variable
organ
degree. So not everybody developed pancreatic. So I have looked at pancreas, right, in our paper for our paper. So not everybody developed pancreatic insufficiency. Not everybody developed, even those with volume loss. There might be some. So the volume loss is variable, basically. Some with minimal loss, some with complete atrophy. And the small portion of patients develop diabetes, insulin-dependent diabetes, which, I mean, I don't know if if you think pancreas has both exocrine and endocrine component, the volume loss is most likely due to exocrine because that is a bulk. But we still see insulin-dependent diabetes in small portion. And I think they develop exocrine insufficiency. Probably they had to give pancreatic supplementation. But
Yeah.
everything is variable. Some recover, some don't.
Yeah. Yeah, the thyroid case you showed had complete atrophy. That patient must have developed a severe hypothyroidism, right?
Yes, they are all that we see very commonly, like initial thyroiditis, maybe some enlargement, or they come from ultrasound for some reason during when the TSH is, I think first TSH comes down, thyroid antibodies or they're elevated, and then TSH is elevated after that.
Thank you so much from KREST and Hyderabad for your elucidative lecture and a wonderful learning for all of us. Thank you. See you sometime next year as well with
Thanks for
another
this
good.
opportunity. Yeah,
Yeah,
okay,
thanks
bye.
so much. Bye bye.